your grades up by the end of the day, probably sometime this evening or so. I don't know what the means were yet on the exams, but I can assure you the points will be added. So it was actually hard. Didn't mean to make it that hard, but there it is. We'll fix it with adding some points. But you should be able to see those grades by the end of the day. We corrected all the fill in the blanks last night. The multiple choice is done, and we just have to make the spreadsheets for those fill in the blanks and upload them. So you'll be able to see them by the end of the day. But let's get started. And if you're, is the camera running? Oh, okay, so we can cut that out. All right. We're going to start with the Starlings Law of the heart. And that's really pretty much where we left off. Last time we introduced that. We said that Starlings Law of the heart, it was a simple idea. It said if you have a greater end diastolic volume, that is, you put more fluid, more blood into the ventricle, you'll simply have a greater stroke volume. And I'll draw that in terms of the pressure volume curve, the cardiac cycle. We'll put that on the board. And I'll tell the story from the point of view of well-conditioned distance athletes, those athletes who are long-distance runners, who are long-distance bicyclists, who can manage after months of training to get their heart rates down around 45 or 50, sometimes even lower. Now, most of us have heart rates in the neighborhood of about 70, but with some training, you can reduce heart rates well into the 40 range. If you do that, though, if you think about that, you still have to supply the same amount of blood to all of the tissues. So a well-trained athlete still needs at least as much oxygen going to all of the rest of their tissues as most of us couch potatoes. So how do you accommodate for that? Well, the answer is that when you slow the heart rate, you still have to have the same cardiac output, and the cardiac output is the cycles per minute times the stroke volume. And so these well-trained athletes simply have much higher stroke volumes with much lower heart rates. And so I'll try to draw that and illustrate the idea of Starling's Law from that concept. And then we're going to start drilling down into the cardiac circulation. And we're going to talk a little bit about the coronary arteries, the arterioles, the capillaries, the venules, the veins, and the coronary sinus. Now, I'll use this opportunity to talk about how blood flow occurs in all systems. I mean, by all systemic systems. And what I mean by that is when the blood comes out of the heart, flowing away from the heart, it's going to flow in arteries. If it's coming out of the left side of the heart, it's going to flow out into the aorta. But the left side of the heart with the oxygenated blood is also going to provide oxygen in the blood through the coronary arteries. Now, what I mean by all of this is to simply reiterate that there's this standard pattern of blood flowing away from the heart through a series of arterioles, branches and branches and branches. Those arterioles feed capillaries, which are the exchange vessels. This is where oxygen is going to leave the blood vascular compartment and go into the muscle. Then it's returned to veins, venules, veins, and in the heart, there's a special collecting site in the right atrium called the coronary sinus. But this idea of this pattern is the same throughout. And what we'll emphasize today is the idea of the capillaries as being the exchange vessels. Those are the extremely thin-walled structures composed only of a single layer of endothelial cells, and the oxygen will now diffuse across that endothelium. But the idea here is that we have a problem because the pump itself, the left side of the heart, is dedicated to pumping the blood through all of the systemic vasculature. And when it's pumping, when that muscle's contracting, it's going to be squeezing shut these very fine capillaries. So when can we find an opportune time to move blood through this specific coronary circulation, which is feeding the capillaries to give oxygen to that piece of meat we call the myocardium? The myocardium is a fairly large piece of tissue, and it's simply too thick to use the blood in the ventricles to supply oxygen to all of those muscle cells. So we need a specialized coronary vasculature to provide oxygen and nutrients to all of the muscle cells in the myocardium. And that's what this circuit is doing. We'll also see that this becomes really important because as we grow older, we begin to block many of these coronary arteries. And I'll walk us through why that becomes such a problem. You start plugging up those arteries and you have insufficient oxygen feeding the muscles of the heart, the myocardium, then cardiac insufficiency follows pretty quickly and you have a heart attack. Well, so to talk about this, we want to emphasize the anatomy of the coronary vasculature. We'll see that there are two main coronary arteries that originate at the base of the aorta. They're going to carry blood out from the base of the aorta and deliver all of that blood to the capillary beds in both on the right and left side. So both to the right myocardium and to the left myocardium. And again, it's the capillaries that then will be the exchange vessels. But what we're going to find is that most of the blood flow that occurs through the coronary system occurs during diastole, which doesn't make sense if you at initial blush, because you think this is when the heart is relaxed. It's not when there's any physical activity going on to drive the blood through the vessels. So the question then is, how does this work? How do we manage to move blood through this coronary vasculature, this specialized coronary vasculature, while the muscle's relaxed? The answer to that is there's pressure in the aorta. And the anatomy of the system is such that the two coronary arteries are located right at the base of the aorta. And that after each cycle of the heart, there's a certain amount of pressure that remains in the aorta. Remember, we opened the aortic valve by the pressure in the ventricular chamber, but it closed again. It closed back over again when there was a greater pressure on the aortic side than the chamber side. So there is pressure remaining in the aorta. We're now going to use that pressure in the aorta to drive blood through the coronary vasculature, and we'll talk our way through that. And then we'll talk a little bit about some of the dynamics of blood moving through vessels and talk about that in terms of coronary artery disease. There are just a couple of equations here, and we'll come back to these a little later too and talk about the vasculature. The first is one we know about, it's Ohm's law, but now we're going to apply it rather than to ions moving through channels, we're going to use Ohm's law to apply it to the movement of fluid through tubes. Again, that requires a differential in pressure. When we were talking about ions and channels, that differential in pressure was a voltage. Here we have a mechanical difference in pressure. That mechanical difference in pressure then works against a resistance. The resistance is primarily the friction of the blood against the walls of the vessels. And this resistance then is going to determine the flow. The higher the resistance for a given delta P, the lower the flow. At the same time, there's another important equation which describes flow, and this looks pretty bad, but we'll simplify it way down. It says that the flow is equal to the differential in pressure times pi, which is its constant, times the radius raised to the fourth power divided by 8 nu L. Well, 8 nu L, 8 is just a constant, of course. Nu is the viscosity. We're not going to change that. That's the viscosity of blood. And L is the length of the tube, and we'll fix the length of the tube as being a fixed length, a centimeter or so. Just to point out that the flow through the tube is proportional to the radius raised to the fourth power. This tells us that the flow is heavily dependent upon the radius, and small changes in the radius will dictate enormous changes to the flow for a given differential in pressure. This is important for the coronary arteries because as we begin to plug the coronary arteries with plaque, that we don't understand why this plaque precipitates there. It probably has something to do with inflammation, and there's inflammation under the endothelial cells, and for reasons we don't understand, we get fatty deposits on those endothelial cells. And when that happens, then we begin to occlude or block off the diameter or radius of that tube. This equation tells you, because the flow is proportional to the radius to the fourth power, it doesn't take much blockage before you seriously impede flow. That's why coronary artery disease is so dangerous. And if there's time, we'll get into the conductal system, but I suspect there won't be. But let's start here with Starlings Law of the heart. We'll just label this as Starlings Law. Dr. Starling was a physiologist in England. I think he worked at Cambridge at the turn of the 20th century. And he established a number of rules of blood flow and understanding pressures and such. But one of his major contributions was the Starlings Law of the heart, which simply stated that an increase in end diastolic volume led to an increase in stroke volume. He didn't understand why that occurred. He just had that observation. It turns out to be true, and we still see it today. But we can now explain this. And first I'll graph it, and then I'll give you an intuitive explanation. Where again we see this as pressure, and this is volume. And we'll start at point A. We'll run a regular pressure volume curve out to point B, just as we did yesterday, up to point C, the ejection phase, and then the isovolumetric relaxation phase. That's what we drew yesterday. Stirlings Law simply reiterates this curve, but with a slightly different twist to it. Remember, this is said to be the stroke volume. And typically, we said the stroke volume would go, in most people, from an end diastolic volume of 120 back to an end systolic volume in the neighborhood of about 50 mils, giving a stroke volume in most people of about 70 milliliters. Well, what Dr. Starling observed was that if there was an increase, in the end diastolic volume, so the end diastolic volume here, rather than 120 and 50, was about 140, 160? 160, let's do that, 160. So now we've increased the end diastolic volume by 40 mils. Then we find that the pressure hasn't really changed very much. All we've done is increase the volume. And at this point, the ventricular myocardium begins to contract. The ventricular myocardium increases the pressure, until we reach the point up here where we open the aortic valve. All we've changed in this heart is the end diastolic volume, and so the pressure required to open that semilunar valve, to open that aortic valve, hasn't changed. Then all of this blood has to be squished out and into the aorta. But again, the pressure here, where the aortic valve closes, that hasn't changed. This is the pressure on the far side of the valve. So this point is pretty much the same. And so we go through the cycle again. But this tells us that the new stroke volume, put it in green, the new stroke volume now goes from 160 minus 50, which is equal to 110. So we've simply increased the stroke volume from 70 to 110. But if you think about this, if this were an individual, and you imagine this were an individual that was a well-trained distance athlete, a distance runner, could be a bicyclist, someone who gets out and runs for hours on end, bicycles for hours on end, requires a really aerobic conditioning. In these people, you'll often find the cycles per second, the beats per minute. I'm sorry, cycles per minute. The cycles per minute in these people can often be down around 45 beats per minute, sometimes even lower. There was a student I talked to a couple of years ago who went in for surgery, and she was a triathlete, so she was really well trained. And she went in for some surgery, and they put her on the surgery table, and they said, "We can't do this to you. We can't put you under anesthetic because your heart rate's too low." So they asked her to get up and run around a little bit to get her heart rate up. But the point was that her heart rate was down in the low 40s. It was because she was such a well-trained athlete. But yet, if you think about her case as being such a well-trained athlete, she still had to provide the same number of milliliters of oxygen to her tissues that everybody else has to, maybe some more. So how does someone with a heart rate down in the mid-40s supply the same amount of blood to all of their tissues as most mortals who have stroke volumes of about 70 mils with heart rates of about 70 beats per minute? Well, simply put, if you multiply 45 times 110, I'm pretty sure this comes out to about 4,950 mils, which is not so far off of 70 times 70 for 70 mils times the stroke by cycles per minute, comes out to 4,900. So this is just an example of Starlings Law given to you through these well-trained athletes who have much, much lower heart rates, but yet still retain the requirement of delivering similar volumes of blood to all of their tissues. And it's the idea that the greater the end diastolic volume, the greater the ejection volume. So that simply then tells you that if you slow down the heart, you can expand the heart and increase the volume. Now let's look at this in just a minute and think about that in terms of what we know about the sarcomeres. Now, Starling had no clue about sarcomeres. Well, he may have known about sarcomeres, but he didn't know what they were doing. And so if we draw this left side of the heart with the atrium and the ventricle and the input here from the pulmonary vein, the blood's flowing in this way, flowing down across this valve and going out through the aorta. And you remember, we simplified it a whole lot yesterday. We didn't get it down into the individual cellular level, but we said that there would be Z-lines here. And that the Z-lines would be organized in such a way that just as we saw in skeletal muscle, there would be the thin filaments and the thick filaments. And we made a big deal yesterday. We said that just as we saw in skeletal muscle, once we contracted the muscle and shortened the sarcomere length, we needed some mechanical mechanism to restretch or reset those sarcomere lengths. In skeletal muscle, that's straightforward. You use the antagonistic muscle. But here we have this issue of we don't have an antagonistic muscle in the heart. So what we use to reset the sarcomere lengths is simply to use the blood flowing into the ventricle and allowing that low pressure return to distend the heart muscle in such a way that we reset or re-extend the sarcomere lengths. What we're seeing in the upper panel with that greater end diastolic volume, as we put more fluid in this confined space of the ventricular chamber, that increased fluid volume is going to pull these sarcomeres farther apart. So they have a longer distance through which they can do work. But when the sarcomeres contract, they will come back pretty much to their same length. So the length of the sarcomere, so the sarcomere length is shorter at the end of systole than at the beginning. But what it tells us is if we have simply more time for the blood to come into the ventricle, we'll stretch these farther apart. So then with Starlings Law, we simply have a longer sarcomere and therefore a greater distance. Through which the contraction can occur. So just trying here to describe how that increase in volume inside the ventricle, so we have a greater end diastolic volume, simply leads to more ejection of fluid out of the ventricle, out into the aorta, shown above by, which fun way to appreciate it, shown by the pressure volume curve, and then describing that in terms of sarcomere length. So any questions to there? Yes?
Does the residual volume of the ventricle ever change? Like, does it ever go down?
So the question here is, do we ever see a change in the end systolic volume, the residual? Not just in Starlings Law. But I will tell you, because I don't want to lie to you completely, is that when we come around to talking about the sympathetic drive in the heart, when we start increasing sympathetic drive, we'll do two things. We'll increase the heart rate, but also in increasing the heart rate, we'll increase something called contractility. So we get a greater strength of contraction. In that case, we're actually phosphorylating calcium channels, getting more calcium to come in. And that will actually make a stronger contraction, not just moving through a greater distance, but a stronger contraction. And because of the stronger contraction, we can sometimes move this end systolic volume a little bit to the left. So we get a little bit more efficient. I'm not sure how far you can go. I bet you can't go more than 50 to 40 at most. So there's always a little bit of volume left at the end of systole. But you can move it to the left, given the right conditions. Anything else? Okay. Well, if not, let's now go to this upper panel. I'm going to get rid of the whole story about Starlings Law here. And I'm going to take this panel, I'm going to leave behind this structure of the left side of the heart. And I'm going to take this panel and label it as the coronary circulation. Now I'm simply going to number here the pathway, the route, and list the route of the blood through the heart. And this is a coronary circulation providing O2 rich, oxygenated blood to the myocardium. Now, while it's true that there's a sizable volume of blood inside the ventricular chamber with each beat, and while it's true it's going to be in that chamber, it can't really reach the myocardium because it's separated from the myocardium by an endothelial cell layer. What's more is the distances between the blood in here in the chamber and the muscle cells here in the myocardium are just too great to efficiently move oxygen from this blood into the myocardium. So just as we see for all tissues, we need to be able to move blood from oxygenated blood from the left side of the heart through to capillaries in the myocardium. So what I'm going to do here is I'm going to list the sequence of events of oxygenated blood moving through the myocardium. The first here is going to be the blood is in the aorta. Second, the blood will be in the coronary arteries. The name coronary arteries comes from the Latin, and coronary simply means crown. And so when the early anatomists were looking at the coronary arteries, that they looked to the anatomists as though they were a crown over the heart. That's the standard picture we've had. Now I'm going to put these in green so we can see them as a different color. But right here at the base of the aorta will originate this coronary artery. Now recognize the way I'm drawing this isn't quite accurate. I've opened this up to look inside the chamber, and what I want you to imagine now is we're not looking at the chamber, we're looking at the outer wall of the heart. And over the outer wall of the heart, there will be this coronary artery, and it's going to go all the way around the back side. The other coronary artery comes round and now comes around the right side. Now, if you take a gross anatomy course, you're going to learn all about these coronary arteries. I'm not going to get into much detail. But these coronary arteries have main branches that form a sort of crown around the ventricles. And then there are a number of arterioles that branch from those coronary arteries. So this structure here is the coronary artery. And there are a number of main arterioles that branch from the coronary arteries. So the third piece I want to put in here then on this list is first the aorta, then the coronary arteries, and third is the arterioles. And there are many of these, and they branch eventually into capillaries. These capillaries are a single layer. They're a single layer of endothelial cells. One of the hallmarks, and we'll run into the schema later, one of the hallmarks of these arteries and arterioles is that they have a lining of endothelium. So it's a lining of endothelium surrounded by smooth muscle. Now, these capillaries then are carrying oxygen-rich blood, and they'll give up their oxygen at that site. So 5 now is going to be venules, 6 is veins, and 7 is a specialized region in the heart called the coronary sinus. And the coronary sinus empties into the right atrium. Now, one of the things I want to point out here is that in the aorta and the coronary arteries, down to the capillaries, the concentration of oxygen in this blood is about 95 to 100% saturated with oxygen. But when the blood has passed through the capillary beds, when it's passed through the capillary beds of this piece of meat we call the myocardium, these muscle cells, the cardiomyocytes, are among the most oxygen-hungry cells in the body. And so what you find is when the blood is flowed through these capillaries and comes back into the return system, in this region, we now have concentrations of oxygen which are in the range of 12 to 15% saturated. Now, of course, the numbers aren't so important there in themselves, but recognize that we have sucked a tremendous amount of oxygen out of the oxygen-rich blood coming out of the aorta by the time it returns. This tells you that we're using enormous amounts of oxygen just to supply the cardiomyocytes in the heart. So that's the root. And what you have to remember envisioning this is that these tiny capillaries, which are composed of only a single layer of delicate endothelial cells, are now embedded within the myocardium. And remember what the myocardium is doing for a living. It's contracting. So these sarcomeres are shortening. And when they shorten, what they're intended to do, of course, is generate a pressure here on the ventricular chamber. But if you have these tiny capillaries embedded within that myocardium, they're going to squish them right shut. So now you have this problem that you are trying to feed oxygenated blood to the myocardium, and the very forces you normally use to drive the blood through the vasculature are now impeding the blood flow through the myocardium. So how do you solve this problem? The answer is that most blood flow to the myocardium occurs during diastole. So we'll write that out. Blood flow to the myocardium occurs predominantly during diastole. When that myocardium is relaxed. When the myocardium is relaxed and you no longer have the sarcomere shortening, during that period of time now, we're going to drive the blood through the coronary vasculature. Well, it's worth talking about here to say that a delta P is equal to the resistance times the flow. What I want to emphasize here is that this is a pressure differential. And if we look at a particular tube, and we imagine that in this tube, this could be the coronary artery, that blood flow is in this direction. We can now say that this is going to be pressure 1, and this is going to be pressure 2. Now, what's going to happen here is that as the blood is moving through this vessel, this is all going to be blood. Some of this blood is going to be up against the wall of the vessel. For those of you who have had some fluid dynamics, bless your hearts, you'll see this immediately because you have done all the integrals and all the calculations of the friction against the wall and how it falls off. All I want you to recognize here, though, is that there is a layer of blood right up against the wall of the heart. And as you get closer and closer to the wall of the heart, the friction of the fluid against the wall the wall of the vessel gets greater and greater and greater. And it doesn't matter whether we're talking about blood in capillaries or blood in arterioles or whether we're talking about oil in pipelines. It's the same idea. And what it tells us is that the greater the volume, the greater proportion of the volume that's up against the wall, the greater the resistance. Because almost all the resistance to movement, almost all the friction of the movement in this tube is going to be against the fluid right up against the wall. And as you move farther and farther away from the wall, the friction gets lower and lower. And that's why you need integrals for that, because it gets smaller and smaller by very tiny fractions. So you integrate against and differentiate against those. But regardless of that, all I want you to see is that you have a friction against the wall, so that if we use Ohm's law, where delta P is the resistance times the flow, this really is the friction of blood moving. This is a friction of the blood moving along the wall. So there is a friction, there's a pressure, and there's a flow. The higher, for a given delta P, for a given pressure differential, P1 minus P2, if this is fixed, then the higher the resistance, the lower the flow. That's all we're saying. Just as we saw in ions moving through membranes. We saw voltage is equal to the resistance times the current, where there we had the movement of ions. Here it's fluid flow, and that fluid is being forced by differential in pressure, and the resistance will determine how much flow you have. That's all we're saying. Now the question I want to point out is, where does this delta P come from? It's simple enough when we're thinking about the systemic vasculature. In the systemic vasculature, of course, we're generating a pressure inside the chamber by the contraction of the myocardium. And then as the fluid moves out into the aorta and moves farther and farther downstream, that delta P gets less and less because you've used up some of that energy by friction against the wall. So the delta P and the flow and the resistance, Ohm's law here is delta P is equal to the resistance times the flow. Well, again, here for the coronary arteries, we have a tube. And we're going to move the fluid through the tube. So the rules remain the same. We need to have a delta P to move the fluid through the tubes. There's going to be a resistance because of the friction of the fluid against the wall. And then there's going to be a resulting flow of the fluid through that tube. The question is, where does that come from? Well, let's look at this slide. This first slide is just Starlings Law. It's what we drew on the board. I'm not going to belabor that too much. So it's worth spending some time with this figure to show how we increase end diastolic volume, and then the pressure volume curve, how it increases the flow out, and then the circuit continues. I'm not going to do that anymore. What I want to do here, this is a figure we're going to come back to, but it's really a useful figure because it shows, for our purposes here today, the oscillation in pressure in the aorta. So you'll see the pressure goes up, reaches, something like 115 millimeters of mercury, and that's at the height. That's where the blood is coming out of the ventricular chamber and out into the aorta. That's where the pressure is the greatest. And then at the end of the contraction, then the blood continues to flow, but the pressure drops. Then there's a contraction. We increase the pressure. Open the aortic valve, the blood goes out into the aorta, and it drops. So with each cycle of the heart, there's an increase in pressure in the aorta, followed by a decrease in pressure in the aorta. But you'll notice there's a sizable pressure. There's a sizable pressure remaining here in the aorta at the end of the systolic period, end of systole. We're now going to use this pressure in the aorta to drive blood through the coronary arteries. So let's take a picture of this. Let's take a look at this. And this is on your right-hand side, this is a much better picture of the coronary arteries than I showed. So coming out of the aorta are these two vessels. Coming out from this left side and the right side are the openings of these coronary arteries. So again, imagine all of these fine capillaries being crushed by the contraction of the myocardium. So we can't really drive blood through this system during contraction. And that's shown over here. The flow of blood, the coronary blood flow during systole is pretty low. Then suddenly at the end of systole, it goes way up and then comes down toward the end of systole. It goes way up during diastole, and by the end of diastole, it's come down. And here again, when we begin to contract the myocardium, the flow through the coronary system is low, simply because we've closed off those tiny capillaries. So that means that most of the flow is occurring during diastole, and what we're going to see here is that pressure is generated from the residual pressure here in the aorta. So we go back to the previous slide. So here in this slide, after the aortic valve closes, then the pressure drops fairly precipitously because that blood is being distributed out to the systemic vasculature from the aorta. But there's still considerable pressure here in between beats during diastole. So this fall here is all during diastole. But there still remains behind a certain amount of pressure in the aorta. We're now going to use that pressure to drive the blood through the coronary circuit. So now, here's the opening. Here's the opening here to the two coronary arteries. And what I want you to see is here's the and here is the aortic valve. When the valve opens, now there's a pretty good whoosh of blood by these coronary arteries. Yes, you had a question?
Are the slides on campus or in the ebook?
Those slides are all in the ebook. So now the blood is coming out. Now during systole, after the valve opens, there's a whirl of blood that goes by here. Now, in fact, right at that time, there's such a whirl of blood coming out of here that there's a certain amount of Venturi effect that's pulling blood out of the capillaries. Out of the coronary arteries. So you have two effects mitigating against the movement of blood into the coronary arteries during systole, during the ejection phase. The first is you've squished shut all of those fine capillaries. But the second is there's fluid moving by this opening. Now, I don't know how many of you still do this or how many of you had organic chemistry. But in organic chemistry, you typically have this side arm, and there's a faucet up here, and water's flowing through. And then you have a rubber tube that goes to a sidearm flask. And this rubber tube to the sidearm flask is such that when you turn the water on, there's a movement of water down through the faucet, through the tube, and that creates a slight vacuum. And then up here you have your Buchner funnel, and you put your product on the filter paper, and when you draw the fluid through, you generate a vacuum here to increase the rate of flow. This is the Venturi effect. You get the same Venturi effect here at the base of the coronary arteries, because when blood's whirling by, it's doing the same thing as the water whirling by the sidearm flask when you're trying to purify your reagents. Well, so that's one of the effects that's pulling blood in the wrong way. But also, at the same time, there's the squishing and compacting of the capillaries. So now, let's see what happens when the pressure on this side is greater than the pressure on the chamber side of the aortic valve. The that force, what's that force going to do to the aortic valve? It's going to close it. But now the same force to close the valve is still in here in the aorta. And that's now going to generate a pressure that can move the blood through the coronary arteries. And remember, I erased it, at point C, at point D, where the aortic valve closes, then you start the period of isovolumetric relaxation. That's the beginning of diastole. So at that point, there's pressure here. These muscles are relaxing. Blood is coming in, distending, increasing the length of the sarcomeres. And it's during that period of time we now have a delta P, a pressure difference here, a pressure difference between the coronary arteries and the capillaries that drives the blood through the capillary beds of the myocardium. Everybody okay with that? So we're basically using that pressure. That's the delta P from Ohm's law. In the last few minutes, let me add one more equation here, and it looks bad, and again, if you take fluid mechanics, it gets way worse. But the equation is Pascals Law. And Pascals Law simply says that flow is equal to the delta P, the differential in pressure, times pi times r to the fourth divided by 8 nu L. Now again, that's a constant, that's the viscosity, that's blood, that's not going to change, and this is for a fixed length. So this becomes a constant. Pi is simply 3.14. If we have a delta P, a given delta P, then the flow is proportional to r raised to the fourth power. That means that small changes in the radius have big changes in the flow. Yes? So this is the radius raised to the fourth power. Where did that come from? That came, I think, from the original observations that Dr. Pascals did in the 18th century, where he was looking at capillary tubes and then varying the diameter of the capillary tubes and looking at the flow through them. I think this was established empirically. But those of you in fluid mechanics will probably tell me differently. I don't know exactly where these equations came from, but this is simply the radius of the tube. And in the last few minutes, let me tell you, there's a real world sort of example to that. And we all know about this. So let's say this evening, and it's Friday, and you go out to the bar, and you order a mixed drink. And when your soda comes to your table, you have this mixed drink, and always in those mixed drinks, they have these cocktail straws. We've all done this. And you look at the cocktail straw, and it has a tiny, tiny opening to it. Now imagine trying to drink your drink through that cocktail straw. We've all done this. So up here, and this is the best I can do, this is meant to be a mouth. This is your teeth. And you take this straw and you put this straw into your mouth. And you may not know it, but what you do when you drink with a straw is what you do is you take your tongue and you drop your tongue. When you drop your tongue, you increase the volume of your mouth. Well, out here, there's a pressure. This is the atmospheric pressure. And when you increase the volume inside your mouth, you now make the pressure inside your mouth a little lower. So that now gives a delta P. So now we have a delta P. We have a pressure differential between the atmospheric pressure here and the inside of your mouth. But yet, you know, if you do this delta P, the flow, let's do it this way, the flow equals delta P, that's the pressure differential, pi r to the fourth 8 nu L. Well, we're not going to deal with this, but you know full well that you don't get much fluid through that tiny opening in that straw. The reason you don't get much fluid is this r to the fourth value. You know intuitively, if you want to get more drink through that straw, get a bigger straw. But that comes back to this idea here. With a tiny straw, a sizable proportion of the fluid is up against the wall. As you increase the diameter of that straw or that pipe, then a smaller and smaller proportion of the fluid is up against the wall. And that's why the flow changes so dramatically with R to the fourth. It's simply the proportion of the fluid against the wall. And it's a surface to volume area question. And I'll leave you with that, and we'll come back next time and finish the story on the conductal system.